Good morning. So this is again, I think, continuous SICS in this hall. Looks like they were also on the SICS. Uh, they don't have the list of the speakers and all that. You have, no? Okay. So it's a yes. This is it. Yes. So possibly SICS has become now, I think, too much talked around every day. So people, I think, yesterday they had it, and today they have it, and tomorrow they will have it. I think we have cataract symposium tomorrow, national symposium, and we will be speaking SICS in that also. So to begin with, to say that SICS is the surgery done in this country more than National Program for Control of Blindness tells that SICS is more than 70% of the cataract surgery in this country. And not more than 20 to 30% is a phaco surgery still in this country, because neither it is universal, it is a machine dependent, and it is a teaching in medical colleges of the postgraduates and doctors is difficult, and not difficult means in the lots of the departments, even the teachers sometimes are not trained in the phacoemulsification. So SICS is a big boon for the country like India. And this is all over Africa also. In fact, most of the African countries, SICS has reached. So we start with the subject of, and I'll invite Dr. Kamaljeet, please come here. At least we look better, so many of us will be together. Yes, and Dr. Sudhir Singh, Dr. So we start with the rock hard cataract, and that is one topic or one disease in the cataract that is a problem with the phaco machine. So I'll get on with it.
इधर आप स्टार्ट कर दीजिए प्लीज.
Forward is this one. So this is SICS in hard cataract. You have seen recently also someone doing, but my method or what I teach in the country is that the incision is not straight. Incision has to be the frown incision, and frown incision with the upward cuts 1 millimeter, so that you don't get the ATR. The astigmatism produced by any cataract surgery is against the rule astigmatism, that is flattening of the vertical meridian. So first we take this knife. It can be diamond knife, it can be steel, but has to be sharp. Make the frown incision, cut first about half of the scleral thickness, and then with a crescent you go around and dissect at least 1.5 to 2 millimeter of the cornea. Basically, it's a self-sealing incision in SICS. Because of that the valve made within the cornea, lighter hai, wo hai, indicator, excuse me, you have the pointer? So, and then rhexis, and all these patients, I think you must put a dye to get a rhexis, and rhexis has to be large enough. The beauty of SICS, even if your rhexis runs away or you have a problem, SICS will be done. And I say that even if somewhere rhexis has run away, you can make another small round rhexis, then another round axis. So still you can maintain a bag. Even if a rhexis has run out, you can maintain the parts of the bags. So lens will be, IOL will be in the bag. So this is a dissection of the wound, which is a larger incision inside. And outside, in such a large, this one cataract generally up to 6 millimeter one can go, but I generally keep my incision up 5 5.5, not more than 5.5. But if you have got a large hard cataract like this, you can go up to 6 millimeter, and it is a, you can see the valve, you can see the red color, that is the, till there is a corneal valve. So this will be like a self-closing door. And once you put a air or a fluid in the chamber, this will get closed. So this is a big one, hard, black cataract, and phaco machine will generally do it, but will damage the cornea, will damage you, your heart. So we must learn SICS for the sake of patients and for the sake of safety of our health also. That some of these patients in India, you still get bilateral, hypermature cataract, hard cataract, and the beauty is that this is a self-sealing incision, and I generally use anterior chamber maintainer as a routine for any cataract surgery. Even phaco also, if I have got a hard cataract, in phaco also I use the anterior chamber maintainer to prevent the surge. So you don't have to have a very fancy, very costly machine. So any machine will do. If you have anterior chamber maintainer, your chamber will be maintained. So this is surgery is done, and then you can irrigate the places where you made the incisions, and then you could do without superior rectus suture also. But for the sake of younger ones, I am saying that if you want a better exposure, you can give a superior rectus suture, but you can do without it. And then, so, you know, these surgery, cornea is the best thing, that cornea will be maintained clear next day. And these patients will have much better vision than any phaco patient. Thank you very much.
So, thank you, sir. And that was hard cataract, I think, which is one of the most important indications where we usually resort to SICS vis-a-vis phaco. And any questions we will take after the, or anyone if wants to ask in between can ask also. I would like to invite Dr. Kamaljeet Singh, sir. He is head of ophthalmology at Allahabad Medical College, and he shall be speaking on Argentina flag sign. So we all know that capsulorhexis is not a prerequisite for, it is of course desirable to do a capsulorhexis, but it's not a prerequisite for SICS. But there would be situations where in a intumescent cataract you have the Argentina flag sign coming in, and how you can manage these patients with a good SICS despite your rhexis not being in place would be now discussed by Dr. Kamaljeet Singh, sir. Sir, you ready?
Yes.
Can you please put his presentation?
Oh. So my topic today is, if you encounter a Argentinian flag sign, what to do. The best way would be to prevent, of course, the Argentinian flag sign, but sometimes on a bad day you would get a Argentinian flag sign, and you should know how to manage this case. You see, the SICS can be done with can opener technique, with envelope technique, or capsulorhexis. The difference between these three techniques is that can opener you can make smaller, there is no problem in that. The envelope technique, when you do an envelope technique, it might extend on the sides and it can go into the posterior capsule. And capsulorhexis you should make about 6 millimeter size, so that you can prolapse the nucleus out of the bag easily and then deliver the nucleus out. So that is, these are the three things that can be done. But at times, even if you are doing 100% good capsulorhexis, you might find this kind of problem. And SICS is best if you have this kind of Argentinian flag sign that you can see on this screen. So this is a very, very important thing, and that is why this name is that you have stained the dye, the anterior capsule with the trypan blue dye, and when you have a hypermature white cataract in the center, you get a reflex of the cataract after the extension of the rhexis occurs. So this is my video, wherein you can see, we, as Dr. KPS Malik and Dr. Ruchi, they are my teachers, and I always make the same kind of incision what they make, a frown shaped incision about 2 millimeter away from the limbus, and go gradually. There is no hurry of finishing the surgery in 2 minutes. And many a time we tell our students that there is a Japanese association of slow surgeons, so that you make a perfect. हम लोग कई बार अपनी शेप भी कराने चाहते हैं तो नौवे से कहते हैं यार जरा धीरे धीरे बनाओ, बाल वाल छोड़ना नहीं. And when we are doing cataract, we say that we finish it in 1.5 minutes, and you might have an accident if you are doing it faster. So you make a good tunnel and then you puncture the anterior chamber. I usually do it. You see, there is a pressure inside, air bubble is not going easily and it's coming out. And we have stained this anterior capsule, which gives you a contrast, and therefore you would be able to do a good capsular access. The important thing here is that you should use a high viscoelastic, and many a times we use a high molecular weight viscoelastic, but still the chamber deepens. The purpose here is to deepen the anterior chamber so that the pressure to the sides is prevented, so that this rhexis may not extend into the periphery. So we keep on putting the viscoelastic in the anterior chamber in the hope that the interlenticular pressure would be reduced and you will be able to do a good capsular access. So then we are injecting lots of viscoelastic to deepen the anterior chamber, and whether I use capsular access, I just did a small nick there in the center and then again injected viscoelastic material to deepen the anterior chamber, but there was this higher pressure inside, and then I tried to hold the capsular access and the viscoelastic again got out, and I thought that I would put this, and you can see the Argentinian flag sign as I have shown you the flag there, and on the sides you have the blue appearance, in the center you have this road kind of thing which is and in the center if you have a sun, then it is of course exactly like you have Argentinian flag sign. So then we have to do, now at this stage we have to think what we can do so that we can solve the problem of delivering the nucleus out. Here phacoemulsification is absolutely contraindicated, because what happens that these two edges on the extreme side, they might go in the periphery and may go into the equator, and from there it might go into the posterior capsule, and you will have posterior capsular rupture and you will not be able to see because the cataract is opaque and you will not be able to see. So that danger is there. So what you have to do is that all maneuvers that you would be doing would be in the anterior chamber. If you do it inside within the bag, then this extension will occur like it occurs in envelope technique also. So now what we do is that we have a flap here and inject more viscoelastic. I give a small nick there, and then with the help of capsular access forceps again we try to make a semi-lunar capsular access, I would say this. So this is made on this side. Again we make a nick. Here the flap is big, so needle is not used. We are using a vanas, and we give a nick there and try to enlarge. Rather it's simply enlarging the opening so that the prolapse of the nucleus becomes easier. So now what we do is that a little we extend it, and extension should be slightly larger because the nucleus is quite large, and so that the delivery becomes easier. And then what you do is that you give a little bit of fluid there, and you will find because there is pressure is high inside, so it will automatically come in the anterior chamber. Then you don't need to do too many maneuvers here because of the chances of extension of the rhexis. Now with the vectis you simply take it out because your incision is large, so easily it will come out, and then visco express the epinucleus, and you will find that your surgery is over. Then you use Simcoe cannula, and be careful, don't push it too hard, otherwise here also the extension might occur in the periphery. And after injecting viscoelastic you can see good reflex, and the rhexis margin is also seen in this side. It has not extended into the periphery, and then you implant a non-foldable lens, and we'll put this haptic beneath the capsular rhexis margin on this side, which can be seen easily, Simply rotate it, don't do too much of manipulation there because of the chances of extension again. So this is what is done, and you will find that your surgery is complete and your pupil is round. There is no problem in this. So you finish off the surgery like this. So basically what I want to say is that in case you get it, and even if you have planned a phacoemulsification surgery, convert it to SICS, bring it into the anterior chamber, and your surgery would be nicely done, and you'll be able to finish the surgery in time without any complications. Thank you so much.
Thank you, Professor Kamaljeet. So you have seen that when you have the situations of hypermature cataract and the flaps run away, that you cannot do the rexis, still you can manage the SICS. As he told, it is difficult or impossible to do phaco in it, but at least I manage phaco in these patients with a high vacuum, and you hold the lens, the nucleus, little, take it out, kind of just keep on holding on the high vacuum, 500, 600 vacuum, and you have anterior chamber maintainer, so you can keep on rotating it like a ballroom dancer and can keep on eating it. So phaco is manageable in some of these patients, and you learn it over the years that you can do it. And he has done very well about the SICS. Is of course when you run away like this, the rexis is not in the place. So SICS is a way to go forward, and you get a very good result. Other thing I wanted to say that patient want sometimes that I want foldable lens. So you can put foldable lens in all SICS patients. There is absolutely, routinely nowadays I put the foldable lenses in all SICS patients. So lens is not a problem, can be put foldable. Thank you, Dr. Kamaljeet.
1 minute. So you see what we can do. I usually use this forceps for doing this rexis formation, but you can go through the side port because there the incision is very, very small and the chances of extension may not be there because visco then does not come out of the wound. So you can use a side port also and do with a cystitome, or MVR vitreoretinal surgeons, they do this micro forceps they use, that can be used for making the rexis. Thank you, sir.
You know, these days micro forceps are available which can go through the side port for doing rexis. So you can maintain.
So in fact, just to add, there were couple of things which I just wanted to add. That one was that the moment you identify that there is an Argentina flag sign, avoid all turbulence in the anterior chamber. The more the chamber is going to be turbulent, that is the shallow and the deep AC should not be there. It should be a stable chamber. The more the chances of this rex is going to wrap around, that is it will extend to the posterior capsule. So one has to be very careful that the moment you see it, please either you just put a viscoelastic till or you're searching for your instruments and all that.
Yes, that is what I did actually. I kept on injecting viscoelastic.
And the other thing is, of course, if you have hold of microforceps, they are actually much better because then you're working in again a closed chamber, so your turbulence again decreases. But most of us would not be carrying microforceps all the time, but if you can actually plan and keep a set aside for this purpose, it really helps in all these patients.
Sir, can I share my? What I do in such cases, first of all, it's excellently managed once the Argentinian flag sign has happened. But what I do, I always do rexis in such cases from the side port, and one mini rexis using the 26 gauge of needles. Then it can be enlarged. Okay. So in that case, I think, sir, your viscoelastic in this case was the HPMC. If it would have been sodium hyaluronate and all that, so it could have better thing.
Rexis also, you can make a small rexis in the center, then you can extend it later also. But when you get this Argentinian flag sign, the moment you enter into the anterior chamber with a needle, you will find that your extension would occur without. Even it does not give you much time. Yes.
It's a frightening sight. When you see this one, that it just runs away, you really feel. So take deep breath, wait, and then plan next move. Thank you very much, Dr. Kamaljeet.
Thank you, sir.
So much.
Well managed.
Next speaker, we have Professor Ruchi Goel, and she is a director professor now. The Guru Nanak Eye Center, you must have heard in Delhi, one of the large eye institute in the country with nearly 300 beds, I think. And she is The small incision cataract surgery books we have written, myself and Dr. Ruchi are the author of that book, and I think it's out of print nowadays. We are trying that it comes out again. It's not available in the market really. And so you'll get soon the new version of the manual of small incisional cataract surgery, which has given the Dr. Ruchi has illustrated almost everything so clear cut that you can understand every word of the SICS. And a lot of people, without seeing our surgery, seeing our faces, have learned SICS from that book. And hopefully that book photocopies are available with people, but original books are coming. Now Ruchi Goel will be speaking on a topic which is again astigmatism. Like you have got a pre-existing astigmatism in a patient, and SIC is one method which can tackle it, that you can plan an incision, length, the site, and everything to correct largely the pre-existing astigmatism, which is you cannot do with the phaco. So you have to use toric or so many things, and it becomes costly, toric lenses and all that. But SICS largely can take care of the astigmatism if you patient have it. So Professor Ruchi Goel, please.
Yeah. So I think this is one of the topics, sir, which all of us regularly we have patients which have pre-existing astigmatism. Of course, with the incoming of Indian intraocular lenses, toric lenses being quite reasonable now, despite all that, there would be situations where you would still need to manage without them. So, astigmatism with just one diopters of the magnitude, you can actually alter it with placement of your incisions. But when the astigmatism goes beyond one diopters, then whatever kind of incision you make, it becomes really difficult to negate it. So this is a study which we carried in our center, and we have published it in AIOC. And basically, what are the strategies to correct pre-existing astigmatism is on axis. When I say on axis, is you preoperatively you do the keratometry, whether you use a automated keratometer or you go for a corneal topography, and then you decide where exactly you're going to plan your incision. That is the, when we talk of on axis, that means the center of your your external incision should match the axis of the pre-existing astigmatism, the steeper astigmatism. Now there are other, of course, the limbal relaxing incisions which people have used, but the consistency of limbal relaxing incisions have not been very good, and that's why maybe it has not become very popular. Toric intraocular lenses, of course, they give very good consistent results, and in patients where you can afford, or you can the patients are willing to buy, toric intraocular lens is the treatment of choice for all these patients. This is the, of course, whatever I'm going to speak, this is what we did, and this is published in AIOC, so you can read the details. So what we did was, where we used a 6mm incision for astigmatism, which was 1 to 1.5 diopters, and 6.5 incision for up to 2 diopters, and beyond 2 diopters we used a 7mm incision, because we were leaving these incisions unsutured. We did not go for incision size more than 7mm, just for the sake of the integrity of the wound had to be kept in mind. So I'll just show you, these are the corneal topographs of some of the patients, and you can see here, this is the K2, that is the steeper meridian is 44.67 at 26 degrees. So you can see this is the corneal topograph, and since the astigmatism was about 1.25, so we did a 6mm incision in this patient, and post surgery the incision dropped down and it became 0.34. So you can see I could reduce some amount of astigmatism, and this is actually our findings which we got after 12 weeks of surgery. The 6mm we could reduce the astigmatism to almost 1 diopter. With 6.5 we could reduce just short of about 1.5 diopters, and with 7mm the maximum that we could reduce was 2.5 diopters. So to claim that, as SICS surgeons, sometimes we do very tall claims that we can reduce astigmatism of 3. So at least with this much incision you cannot, if you have to increase your surgically induced astigmatism to more than 3 diopters, then you have to go for larger incisions. And there the problem is that if you make a unsutured tunnel of 7.5mm, you may have post-operative complications which we are all aware of. So, you have to strike a balance between what you want to induce and what you can actually induce, the problem complication that can occur. So I'll just show you how we went about. So first of all, the most important thing is that this is the preoperative marking. Now, what I mean by, see, when you give a block, what happens is the eye tends to rotate. So you must mark your 90 and 180 degree beforehand. If you don't have access to a bubble marker, a slit lamp marking is good enough. So you can just make the patient sit on a slit lamp, make the slit horizontal and mark your 90 and 180 degree. Remember, these markings tend to get smudged. So what we use is, we use either a GV paint or there is a marking pen, and sometimes we actually use a 26 gauge needle to scratch it a little on at the limbus. Some people also make use of pre-existing vessels to mark the 90 and 180 degree, because if your markings are missed, it becomes very difficult to do your subsequent steps. So this part is very important. And here I have shown a bubble marker where you place the bubble in the center of these mark. That means this is exactly horizontal, and there you mark it 90, 180, and you can also mark over here. Sorry, this is 180, this is 90 degree. So after that, so this is on table, this is the Mendy's marker, and you mark your axis. Like in this patient, I think it was 167 degree, and you mark exactly this the incision size. Now remember, here our target is to induce astigmatism. It is quite different from what you were seeing in the previous presentations. So if you want to induce astigmatism, what should you do? You have to go closer to the limbus, you have to make a shorter tunnel, and that means 1 millimeter scleral tunnel and 1 millimeter corneal tunnel, or maximum 1.5, not beyond that. Because if you make a very long width of tunnel, your surgically induced astigmatism goes down. So now we have to go in the reverse direction. So this is why, and what I have done is, I have left a, can you see this frill of conjunctiva over here? So when you are leaving large incisions unsutured, they need to be covered with something. And the most important part, when we realize that all our patients are going to be old, and most of them would be having an against the rule astigmatism. And when these patients are going to have an against the rule astigmatism, that means your incision is going to be temporal. So that is the area where it is going to be totally exposed. So if they are going to be totally exposed, you are going to predispose them to endophthalmitis. So I have to cover my incision with something. So what I did was, I kept this conjunctival frill over here, so that after the surgery, I could at least cover my wound with the conjunctiva. So that is a very important step again. Now, I think the lesson that we learned was that we should teach our residents to do a temporal SICS, because if they really want to negate this astigmatism, all your patients going to be with temporal SICS. Now you see the placement of this ACM. Normally this is the 12 o'clock position. Normally the incision would be here, and your ACM is going to be here. Now your ACM positioning is changed. So if your incision is here, your ACM is positioned over here. So this is another change that you have to practice. And the incision, of course, there is nothing difficult, nothing unusual about it. The nucleus is prolapsed as it is. Now people who are used to using superior rectus, they have a little trouble, because there is no superior rectus to help, because here you are doing a temporal SICS. So, but because the incision size is reasonably large, you are not going for 4.5 or 5 millimeter incisions. So otherwise, if you can make use of viscoelastic to deliver the nucleus, and this is of course the hydropressure which has been used, and this is the IOL placement as usual. What I started doing is another modification, which I'll show in my next subsequent presentations also, is that after doing this is what I was trying, this is securing the wound totally. So even if you have to enlarge your incision to maybe 7.5 and your tunnel is good, make sure that you cover it properly with the conjunctiva and keep a watch on the patient. That is one thing. So to reduce my post-operative PCO also, what I've started doing is, most of us have phaco machine in the hospital, and we have your bimanual port. So what I do is, I use the bimanual to do a polish, because with this method of aspiration, sometimes the polishing is left, and not only the, even if you're using a PMMA square edge and your capsular is not properly polished, you end up with a posterior capsular opacification. Here, when you're trying to, it's a kind of a refractive surgery when you're trying to decrease the astigmatism. So you need to have a patient who does not even develop PCO. So you can do these minor modifications to improvise and improve your surgical results. So to conclude, the maximum astigmatism that we could correct with the 7mm incision was 2.5 diopters. And another thing which we commonly read is that the surgically induced astigmatism is less in the temporal incisions, which of course, because of the greater horizontal length of the limbus and factors like the blinking reflex of the lid is not there, it is known that temporal incisions cause lesser astigmatism. But in our series of patients, we did not get statistically different results, which was again, before I did this study, I had this premonition that superior is worse than the temporal in that respect. But then we had no difference in SIA. The integrity of the tunnel could be maintained and the wound could be left unsutured stably till 7mm if you have made a good incision. If your tunnel at any point of time, you have made irregular planes or something, then in those cases, of course, your surgically induced astigmatism can go higher. So again, people who claim that their SIA is larger, maybe because the wound integrity may not be that good. The other thing that can do, if you give too much of postoperative steroids, what happens is there is delayed wound healing. That can induce more astigmatism. And if your corneal length of incision becomes less, that also induces more astigmatism. But to create a stable wound, we chose to keep 1mm on either side of the limbus and a good plain incision and a covered tunnel. So thank you so much. That is all in this presentation.
Ruchi, you covered so well the subject of the astigmatism, and you can handle it if you know pre-existing and where to put the incision and all that. I just wish to ask you a question really, that the person sitting here, you left the frill of the conjunctiva near the limbus so that it can be sutured back. Still it is a large disease.
So it's not suture, it was cauterized.
No, yes, it is co-opted with a cautery. But what I'm saying that these large incisions sometimes do open. So if you have to suture it, tell them that which kind of suture we generally do. We don't do the vertical suturing in these large incision, we do the horizontal suturing. So tell that suture which you do, figure of 8.
Sir, here the idea was to induce astigmatism. If I put a suture, I could
No, I understand that.
So otherwise we put a figure of 8 suture to seal the wounds which are larger in size. So if your integrity is not good and you are not able to, when you are hydrating, you feel that the chamber is somehow unstable. For the sake of safety, you must put a figure of 8 suture. But as I said, this was an entirely different perspective where we were trying to. So if you put a suture, you cannot induce that astigmatism. That is all.
Just to say that the horizontal suture generally don't induce the astigmatism. That is the reason for that. That vertical sutures will produce the myopia on the vertical meridian, but horizontal sutures generally don't induce anything on the cornea. So figure of 8 means that you take from one, go this side, go this side. I think you can do it. Figure of 8, or we call it infinity suture. Next to speak is Dr. Sudhir Singh. He's speaking now. Dr. Sudhir Singh is from Rajasthan, Mount Abu, and Mount Abu is one place of pilgrimage where Mataji is? Brahma Kumari's headquarters. And he has got a hospital of the Brahma Kumaris, and he does so many cataract surgery every day, and he does everything, phaco and SICS and everything. So excellent surgeon from Rajasthan, Dr. Sudhir Singh. So he will be speaking about a posterior capsular cataract. So posterior capsular cataract, you know that it is sometimes difficult to diagnose or sometimes misnomer. So many times you call them the polar cataract, posterior polar cataract, but they may not be posterior polar cataract. If you do so many of them, we say them posterior polar cataract and show that great surgery, that I am doing this, I am doing that. But most of the time, posterior polar cataract are overdiagnosed. They mostly separate away, and mostly you can do that surgery in them. So you will be dealing with the cataracts which are in the posterior capsule area. Dr. Sudhir, please.
First of all, at the outset, it's always great honor and pleasure to be a part of your symposium and your talks along with Ruchi Madam, Kamalji sir. Sir, I would say with all like scientific evidence that Dr. KPS Malik sir he's the like we call him with respect as a father of SICS in India. So he has done so many things, publications, so many techniques and all that. So Dr. KPS Malik sir is a source of inspiration of many young ophthalmologists since my experience in this field is around 24 years. So since beginning, I am seeing sir's presentations, sir's talk, and all that. With all that out is, I'm going to touch a very people call it posterior polar cataract. So I want to share simple pearls about the posterior polar cataract, how to minimize the complications, or if you have any complication, how to deal with simple techniques. So first and most thing is in planning the capsule or axis. So your capsule or axis, this is a posterior capsule cataract, and why you can see how it's going to be difficult. And just first thing is to do a proper axis, and because all these cases like posterior polar cataract are soft cataracts, so I plan usually 5 to 6 millimeter of capsular axis. Idea behind this size is that if you going to have a rent PCR, so you can plan your IOL in the sulcus comfortably. So I always do hydro procedures in the posterior capsule. It's just hydro dissections as well as hydro delineation. So first the nucleus is taken out from the danger zone. That means you are separating nucleus from the epinucleus. And if you are going to do even phaco, this technique is good for that. People are saying that if, they require femto to do this posterior capsular cataracts. They are not required. Nucleus is safely taken out as you can see. Now, please just give attention to this. Now, two small hydro, this like cortical expression procedures. This is hydro expression of the cortical plate. So I am doing it with the titrating the pressure by pressing the posterior lip here. And this is now this is viscodissection. You can see this is viscodissection. And this is quite controlled, and it's not recorded in that clarity that I was seeing that time in the microscope. So now most of your like the dangerous part is out. See, this is visco, and before this it was the hydro. This is going behind, and this nicely separated and dissected. So, as Sir KPS Malik said in many talks, so this is science, art. This is art also. SICS is an art. So every scientist should learn it. And now this is irrigation aspiration from the side port, and this is water height is low. Now second case, you can see this is truly a posterior polar cataract, badly adherent to the posterior capsule. Again, the this capsular axis size is going to be 5 to 6 millimeter, and in this case, it looks just like it's going to be a dangerous case. So vitrectomy machine was ready. At standby mode. Always with the posterior polar cataract, I keep my vitrectomy machine ready. The axis done. You can see this is the margin needed. Now again, hydro procedure. So just take out the nucleus first. Idea behind taking out the nucleus out of the danger zone is to just in case there is a rent, so you should not have a nucleus drop, particularly for the centers those who are not having vitronitrile support or the techniques. So for that, now this is IEA is planned by manual, and now you can see
the epi nucleus plate is badly stuck to the posterior polar. So I'm trying to, but it's badly adhered to the posterior capsule. So there is a rent, PCR. Now, if such situation happen, then you put your the irrigating probe behind the. Now you see this side now. This is a rent. Okay. Now you give support with this probe, hydration probe. It's going behind, and now you try to suck it. So it will prevent to this going behind the PCR. So now second part is the anterior vitrectomy. So for this anterior vitrectomy, keep your parameter highest cut rate of machine, vacuum is moderate, and now after this the material is sucked, and keep your movements of cutter easy. Now after vitrectomy, remaining cortical matter is taken out. It comes out easily if the area is free from the vitreous. And this is PCR, you can say, a big PCR, posterior capsular rent. After this, we always plan the PMA variants in the sulcus, and we found these are the safest lens and with less uveitis and all that. So this is our preferred choice of lens. Once they are fit in the sulcus, they are always fit for life, you can say like that. And this is a technique. It's a small video, so edit a small clip, but full videos are available on my YouTube channel of all these cases. And as Sari said, we are just putting unedited video just for the teaching purpose. We don't want to hide anything. What is happening is that it should be displayed to the colleagues. Now, important part is this. See, this is the remaining cortical matter, and vitreous should be removed. Otherwise, it will lead to inflammation. So, see, this is again, this is a one port irrigation and this is a cutter. First, the things is clear in front of the lens. Settings are same, and maintain your calm and coolness. No need of any panic. Now I'm going. Okay, it's I think shortened. So can I? This clip is cut, so I can continue. I have to go in the folder. 1 minute, sir. Oh, okay.
You know what all precautions you need to take in a posterior when you suspect a posterior polar cataract.
Okay. So fine.
So very well. Thank you so much, and your surgery is good, and you see that you don't be scared of that the posterior white-looking thing that I am in danger. So you are not in danger. You have seen that very beautifully. You can do the visco dissection around it, slowly visco dissection, not the hydro dissection. So visco can separate it, and you will find that most of the time the so-called posterior polar cataract gets out, and it is at the most, if it leaves a little rent, round one, small bit, say 2 millimeters, then you can do exactly what you are doing until unless there is a vitreous in the chamber and other things.
I think just to for the sake of the audience, whenever you feel that you suspect a posterior polar cataract, and you're doing a hydro, remember, don't do a hydro dissection. You need to do a hydro delineation. The point is, when you're trying to rotate the nucleus will not rotate. There would be cases where you have a total cataract and you're doing a hydro dissection when you're not aware it's a posterior polar cataract, and you see that the nucleus does not rotate. Please suspect a posterior polar cataract in those cases. That is one tip. The other thing that you have to be very careful is, once you are now working on the lines that it's going to be a posterior polar cataract, Just do a hydrodelineation, whatever method of cataract lens nucleus extraction you want to do, you go ahead with it. And after you have done that, remember the chamber should not collapse. When you are doing your cortical aspiration and you identify the rent, remember there should be no more turbulence in the chamber. While you are, taking your instrument with the side port, please inject viscoelastic so that the vitreous interface is not disturbed. So that is another key point that has to be taken into consideration. And of course, once you have finished you're placing your IOL, you can use tricot and see there are no vitreous strand and do a complete vitrectomy and suture the wound. Do not leave it unsutured if you have disturbed the vitreous. I think these are some critical points that one has to keep in mind when you're doing a posterior.
Ma'am, give me 30 seconds. Just please give me the part is just 30 seconds.
Yeah, sure.
Give me the axis.
So,
He has got some clip to show that it is there.
so after that,
So now we are going behind the lens. This step I want to show. Put your cutter behind the lens and clear this behind the lens part, central part, thoroughly. And this is going to decide the fate of your vision, post-operative vision. So it takes a little time. Go behind the lens, as you can see, and do safely because
Vitrectomy,
and
yes.
this is after this condition. So thank you very much for giving me the
Thank you,
opportunities.
Dr. Sudhir.
Thank you, Dr. Sudhir.
Enlightened. And next
yeah,
is
so we have after this we have coexisting glaucoma and we have corneal opacities and SICS in subluxated and microphthalmic eyes. I think the program is not circulated properly, so we have these presentations. Sir would be presenting on SICS with coexisting glaucoma.
where it is there here. I don't find it here. Is this one glaucoma? No.
Which is kind of folder.
So this is SICS in advanced glaucoma. The advanced glaucoma, sometimes, people don't do the near total cupping of the optic nerve head with or without. Severe visual field loss, what we call advanced glaucoma, is that you have 10 degree or less of the field around fixation, and scotoma is encroaching or splitting the fixation. So you want reduction in IOP peak, you want diurnal short-term fluctuations and long-term changes. So there can be fluctuations of the tensions in these patients, and that is very difficult. Means like if you have got a near total cupping, then these patients go to really wipe out. That vision can be wiped out. So of the risk of wipeout, they have to be told that you can sometime, but not. I have not seen in my life that somebody has become blind by doing the trabeculectomy or cataract in advanced glaucoma. So IOP to be lowered slowly intraoperatively to avoid suprachoroidal hemorrhage. So the posterior, if you have got there are patients that you have got the tension patient. So suddenly you don't decompress it. So in the side port, you make the side port, then leak it slowly. Press it, little leak. Press it more, little more leak. So you decompress the chamber slowly to avoid the subchoroidal hemorrhage and aqueous misdirection. And you can, in these patients, use the preoperative mannitol or acetazolamide, and of course slow decompression via parasympathesis when we are operating. So this is a patient, and this is routine incision, and generally I told that I do nearly 5.5 to 0.5 frown incision, and I am doing trabeculectomy with it. So this is the same incision. I have made the rectangular flap also. So this is trabeculectomy will be under it. So this is what I called combined surgery, and this is special flying eagle type of incision. That was the shape is, we published it like a flying eagle. So flying eagle means that is a eagle flying, so that kind of incision it looks. See, this is looks like two wings and the center body. So you don't have to do, you can do separately the TREBI and the SICS, you can do separately FECO and the TREBI, but this is TREBI, SICS in same incision. And just you have to maintain the integrity of the frown incision and this flap, quadrangular flap, which has to be virtually lifted very, very slowly from the bed of the sclera. And then nucleus is flown out by the antechamber maintainer fluid. And little modification we have done in that, that if your nucleus is really struck up, you can inject the viscoelastic through the antechamber maintainer. A slow viscoelastic through the antechamber maintainer will raise the little pressure in the antechamber and push the nucleus into the outside tunnel. So that is little modification, but you have to be careful that it has to be very slight, very slow injection of the viscoelastic in the chamber. So this is now the posterior incision, and you see this is a quadrangular, it is not any kind of a punch is used, but it is a little bit of the area of the this subscleral sclera, kind of one sclera, and beneath that the part of sclera near the limbus is cut, and of course you have to suture this flap which is quadrangular. So these on the angles, corners, only two flaps are sufficient sometime, because your tunnel is intact, your everything is intact, or you can sometime, mostly two sutures do it, but flap making, the blab making incision, Dr. Ruchi does that, and she taught us also that we can suture the conjunctiva on the side, but she takes some time, suture from one end to the conjunctiva, then to the cornea, then back to the conjunctiva. So that makes it a blab kind of, that it will be a good one to make the blab. Thank you very much. Thank you.
Okay. कोई नहीं चलो.
Please keep your questions ready. We'll take after presentations, and we'll have a nice discussion after. So if you note down,
you will have time that you can have questions, and we can,
yeah,
you will answer your every query.
Yeah.
And in the last, I'll tell you that if you don't have FECO machine or the FECO emulsification machines, and you have a vitreous in the chamber, and you want to do IOL and everything, how to manage the vitreous, they all will abuse me that why don't you have the vitrectomy cutter or vitrectomy machine. So I am old timer. I can manage the vitreous without FECO machine also. Dr. Ruchi Goel speaking on now, not the subluxated cataract.
Microphthalmic.
Microphthalmos is another big topic where the surgery is difficult. The cornea and eyeball is small, but lens is same big. So managing the microphthalmos cataract surgery is quite a challenge. So Dr. Ruchi Goel is talking about that.
So when do you call a patient having a microphthalmic eye? So the standard definition is when the axial length is adjusted for ages below 95th percentile. So for different ages, there is no set axial length that we will call it as microphthalmic. So as the eyeball grows, we will take the microphthalmic eye would be 2 standard deviation less than the plus minus mean. So now the categorization is important. Why? Because our surgery, our IOL is going to depend on that. So normally microphthalmic eye, it is divided into a complex microphthalmos and simple mean is the nanophthalmic eye, which I think commonly sometimes we operate also and we get to know that it was a nanophthalmic eye later on. Because here only the anterior segment and the posterior segment are short, but the lens per se is of normal size. So usually the patient will spend his entire life, and when the lens starts growing, they get to know that something is wrong. So that's the nanophthalmic eye. And of course, you can diagnose it preoperatively with the you do an ultrasound B scan and you see the sclerochoroidal thickness is more than 1.7 millimeter, the corneal diameter is less. and the lens to eyeball volume, which is the most important part, is about 11 to 32%. Now, many of these patients, of course, would be complex microphthalmos. When we say complex microphthalmos, that means they would have a coexisting coloboma. So there would be some colobomas, or there can be persistent hyperplastic primary vitreous. So a good preoperative examination is important. Now these patients may have microcornea also. So now the problem arises how to proceed with the surgery, and what should be the the standard intraocular lenses which are available with us. They would not have, if it's a very small eye, you cannot implant those lenses. So you have to get a custom made lenses at times. If what I have observed it, if your the corneal diameter is less than, the white to white diameter is less than, let's say, 9 or 8 millimeter, the 8 millimeter, below 8 millimeter, it is better to get a custom made lenses. Otherwise, improvisations as can be done is that what we do is we cut the the IOL optic is left intact, and the haptics can be cut by the sides and cauterized so that they don't injure the capsule. But these are just improvisations. The best is, of course, if you can get a custom made IOL for these patients, and we have an Indian company who helps us with this. So why these patients are, again, they may have some systemic congenital malformations for which you need to get them investigated. They of course, your anterior chamber and the posterior chamber are going to be shallow. These patients may develop PAS in the long term. They may present with chronic open angle glaucomas, and the pupils are usually poorly dilating, which is another problem. So let us see how to manage this case. So this is a patient with complicated microphthalmos, and see, I have not worked on making I'm not interested in making a frown incision, inducing least astigmatism. My priorities have changed in this patient. I want that without injuring any of the intraocular structures, my nucleus comes out intact and I put the IOL. So here my incision is closer to the limbus, and it is a straight incision, so that if I need to enlarge it, I can enlarge it comfortably. So, and the pupil was not dilating, and so I have used iris retraction hooks to dilate the pupil. The rhexis, of course, you have to manage. It needs to be a large rhexis with such a big nucleus, and it sometimes becomes difficult. Now, the internal diameter of your incision has to be about 8 to 9 millimeter. Now, another modification that you see again here is, see, this is the area where your zonules are going to be weak, because this is the area of coloboma. So you expect the zonules are going to be weak. So this AC maintainer, instead of putting here, which I usually do, I have shifted it to another side where my zonules are intact. So these are a straight incision closer to the limbus need be, because what happens is the nucleus in these patients is very large. So, and your anterior segment is small. So if you make a very small, incision, what happens is there is a fish mouthing, and this nucleus will not come out. So what you do is you make it closer, so that the whole, it's something like an extra capsular done in a in a triplanar way. So the mouth opens and the nucleus is delivered. So after doing that, so the rhexis was large and this nucleus came out. Now again, if you see carefully, you can see this capsule is folded. That means the zonules on this side are very weak. So after doing a cortical aspiration, I need to stretch my bag. So what I have done is I've injected viscoelastic, and I'll now, after putting, because again, if you have weak zonules and there is a lot of turbulence, you don't want the remaining zonules also to break. So what I've done is I've put a suture. I've used a bimanual to remove this cortex from the 12 o'clock cortex. 12 o'clock cortex has been removed with this by this improvisation, and now I will put my CTR. If you have an injectable CTR, it is better. It goes right into the bag. If you don't have, then you don't have an injector, you can simply dial the CTR in. Actually, you can create an injector in your OT itself. So instead of using a PMMA lens, which while dialing I would have injured the zonules, I've used a foldable lens which is now injected directly into the bag. So two things I have managed by these small modifications. Now this is a coloboma which is present inferiorly. So what I'll do is I'm doing a McAllen suture to repair this coloboma. Remember that these patients may need a laser barrage. So if you have not done a laser barrage, please don't do this pupilloplasty right now, because this patient may require a complete retinal examination and a laser barrage, which needs to be done. So this patient, already a laser barrage had been done earlier, so I have gone and done a pupilloplasty on the table. So now you can see this is the patient where there were the zonules were broken. Now I'll show you another patient now where everything went wrong. So I'll show you how, after my own mistakes, I learned how to do a better management of these patients. This is another patient where again you see the corneal diameter 9.5, the axial length was 16 millimeter, and this is the superior incision that I made, and I did a very nice tunnel dissection, a frown incision, 2 millimeter from the limbus. So this is one very well dissected tunnel. There was nothing wrong with the tunnel. The chamber was extremely shallow, so again remind you, you either make use of high molecular viscoelastic, they also then you need to inject again and again. So after this, I did see, this is where my first mistake was. I put my ACM right where the zonules were weak. So by the fluid which is coming from the AC maintainer, you are going to further break the remaining zonules. Then I did not use any device to enlarge I was overconfident. I thought I am able to do SICS in any condition, so I decided to go ahead and do a rhexis. But I cannot create a very large rhexis in these circumstances. Shallow chamber, non-dilating pupil, my rhexis cannot be more than 6 millimeter in this case. So the nucleus, remember, the nucleus is going to be very large here. So you need a larger rhexis for the nucleus to come out. So again, this rhexis has been complete. And then after this, I completed my tunnel. It is a well-made tunnel. There was nothing wrong with the tunnel, but the width of the tunnel was too big. So now the nucleus. So you see this large size nucleus, this nucleus is refusing to budge out. I have injected, usually in one this fluid injection, my nucleus pops out into the chamber. Another struggle. Maybe by this, at this stage also, I could simply have enlarged my section and convert it. But overconfidence can sometimes kill you. Now again, I have started trying to deliver the nucleus. It's not coming out. There's no space for the nucleus to enter the chamber. The chamber is shallow. The tunnel is not allowing the chamber, the mouth to open up completely. And ultimately, see what has started happening. Multiple maneuvers, there is an aerodialysis now. So that's how you create a mess. Now I've removed my NTA chamber maintainer. I've used a viscoelastic, managed to finally somehow bring this nucleus out with all the iris into the wound. Even at this stage, again, I would say please enlarge the incision. There was no need to continue with SICS. Simply give one side extension and the nucleus would have come out, and we could have saved all this trouble. So the nucleus is still such a big nucleus, it's still not coming out. So there is no role of this kind of a surgery in these kind of eyes. Remember that you have to have a larger incision. So please don't go for frown beautiful incisions. So this was a very large nucleus, and of course, besides the PC which was left intact, everything has been injured. So anyway, this patient we had not planned an IOL. So to conclude, you must rule out any malformations in heart, kidney, CNS. You must do a wide to wide diameter to see the IOL power, the axial length, the B scans for any RD, pre-existing RD, and of course your IOL power calculation has to be done with Hofer cube formula. You should not use your routine SRK upon T formula, and of course the other points I've already emphasized. Thank you so much.
Great presentation on a topic which is difficult, and Professor Ruchi has shown it all that microphthalmos patients, the lens is big, eye is small, so be careful, and in time decision, sometime to extend the incision will do a good to you. We are taking a break of a minute to condole the death of a colleague No, sir wants it now. Just लगा हुआ just. Dr. Professor Kamaljeet Singh, Dr. Ashok Garg, possibly everybody in North India, we have in the newspaper read it all. Dr. Ashok Garg, who has written many books from Hisar, he expired a few days back, so a little bit of condolence on our part. So, Professor Kamaljeet.
We all have read books from Dr. Ashok Garg, who belonged to a small town called Hisar in Haryana. He was MS and PhD and was an excellent NTA segment eye surgeon. And he has written several books and has pioneered work in the field of ocular therapeutics, SICS, microphaco, and refractive surgery. He obtained his master's degree in ophthalmology from Rohtak and PhD in NTA segment surgery from Belgium. He created a world record for writing maximum number of international ophthalmology books in a calendar year in the year 2006. And for this achievement, his name was included in prestigious Limca Book of World Records and Guinness Book of World Records. He was a reputed international IBC selected him for leading health professional of the year in 2005. He has been awarded more than 15 prestigious international awards, especially Mother Teresa International Award for Excellence, Eye Implant Society's Literary Achievement Award, Medical Excellent Award, International Gold Star Millennium Awards, and so many other awards he won. And unfortunately, he expired a few days back in his town because there was some committed suicide because of some problems there. And we would request you all to stand for 2 minutes silence for him.
2 minutes silence.
Thank you.
Next speaker is again, I'm tired. Dr. Ruchi Goel will speak on the subluxated cataract. Again, a topic which is of importance to you all, that subluxated lens you have and the challenging situation. In fact, most of the patients we have talked here are those difficult ones, whether postiopolar or a microophthalmos or a Argentina flag or very hard cataracts. And she will be talking of subluxated cataract and SICS in subluxated cataract.
I want to add, just for previous talk, microphthalmos, I want to say something.
Yeah.
Yes, madam, the talk was excellent and nice collection of the microphthalmos cases. And particularly these are the cases of crowding anterior chamber and large nucleus and all that. So as Dr. Ruchi Goel has suggested, the biometry part and like management of nucleus is very difficult and tricky, and so SICS is the only safest technique despite of all, because if you are going to do phaco, your AC depth depth is very less, and if you are going to use the any machine, pupil are not good and power is more. So SICS is the safest method, and madam has done justice to the topic, but although it was very difficult topic to manage this. Thank you.
Thank you. Thank
Sir,
you.
I beg to differ. You can do phaco in microphthalmic eye. There's nothing wrong. We do it regularly. Only these cataracts were very hard. That's why I did an SICS. But if you want to do a phaco, you have to do in the bag. A
You can
direct
do
chop
everything,
in
yeah.
the bag.
You can do everything. So
So,
we are not you.
So anyway, let's go on to the subluxated cataracts. And to begin with, one thing is that when you are doing a pre-operative examination, you need to know why the cataract is subluxated. So the etiology part is very important. Why so? Because there would be situations where this subluxation may be generalized, like a hypermature cataracts. There would be situations where it would be progressive, as in pseudo exfoliation. So you may have subluxation in one quadrant, but eventually after doing a surgery the patient may continue to have increasing subluxation, and there may be a situation where the patient comes up after years with the entire IOL and everything into the vitreous. So you must identify what you are dealing with, and there would be patients of ectopia lentis who have presented late, and these ectopia lentis patients, there may be subluxated, but the remaining zonules are usually quite stable. So these are the different situations. And the other thing is, many of these patients like Marfan syndrome, these would have a predisposition to development of retinal detachment. So you have to not only check these, and there would be other congenital malformations, like there may be you need a complete cardiac evaluation, because during anesthesia the patient may have a problem. So once you get a patient of subluxated cataract, your planning starts well in advance, not only as to what kind of procedure you're going to adopt, what kind of device you're going to use, but how you are going to manage the patient pre-operatively and post-operatively. Now the other thing that you have to keep in mind was that before you start the surgery, you say it's 3 clock hours, 4 clock hours subluxation. But when you actually start the surgery, you may realize that the subluxation is far more than what you were actually planning to do. So it is always to keep the complete set of devices. I always keep a CTR, a capsular tension segment, and a scleral fixated lens standby for all my patients with subluxation. So you talk to the patient and say that you're going to return rest of the devices, but on table you may have to change your plan. So these are the different commonly used devices. The CTR, that is the capsular tension ring, I had shown in the previous surgery also, and that is one thing I think all of us must have it in the OT, always readily available. Then of course these are the CONE devices, that is the modified CTRs, where it has a hook which is at a level of your ciliary sulcus. So it is above the capsular bag. It is not within the bag that this eyelet is placed. Now there can be single CONE or there can be a double CONE. And these devices, the disadvantage, I used to use them quite often, but the disadvantage is these are very bulky devices. These are made up of PMMA, and while inserting these devices, there was lot of zonular dehiscence, and so eventually I have actually started I don't use these CONE devices any longer. Instead of that, you can दोनों अच्छा. Instead of these devices, you can actually go in for capsular tension segments. These are very small devices, and there is an eyelet over here, and they are made Indian manufactured, very cheap. So you can use this eyelet for this purpose, and you can combine it with the CTR to stretch the back. And since it is very small device, it is very easy to insert. It does not injure your zonules while inserting. So I have totally given up all my CONEs to CTS with CTR. Now if you need to stabilize your bag at 2 areas, you can put in 2 capsular tension segments instead of 1. So let's go and see the videos now. एक मिनट देखना, इसका वो वाला वीडियो 7 वाला है कि नहीं, चल क्यों नहीं रहा, उसका फोल्डर में वीडियो डला हुआ है कि नहीं, कभी उसका
फोल्डर, लुक इन द फोल्डर.
नहीं तो मेरे पास पेन ड्राइव है उसमें. हाँ ये होना चाहिए. या आई थिंक So you can see the here, this was a patient of post-traumatic cataract with about 4 cloacas of subluxation. So I was wondering what to do, whether to go in for a CTS and fix it up or just do a CTR. So now whether to put in a CTR before you remove the nucleus or put it afterwards. You can put it beforehand if you feel that your zonules are very unstable and it is difficult to complete the surgery. You see there's a large subluxation, so I decided to put the CTR beforehand. The problem of putting it beforehand is that it becomes very difficult to sometimes remove the cortical pieces. Now this is another patient where there is a trauma and you can see the entire capsule is also ruptured. So the mandatory requirement for all these devices is that your capsulorhexis has to be intact. So what I did was I created a capsulorhexis in an area which is away from the area where the entire capsule was torn. I completed my capsulorhexis, and of course nucleus management I have not repeated again and again because it is done in the similar manner. And after this you can see this is a partial thickness scleral flap, and here I have used a Sioni, and this you can see it's a very bulky device, and this eyelet was fixed over through the suture. Like in a scleral fixation, you tie on the suture, the proline, ninoproline has been sutured to the eyelet and it is brought out through these exit points over here, and you tie them just beneath the partial thickness scleral flap. So, and after that, instead of going in for a PMMA lens, I have gone in and injected the IOL right into the bag, because remember here the capsulorhexis is small in size, so I don't want to fiddle with it. This is another patient where there was a large subluxation and it was almost more than 180-degree subluxation, and see I have used these are the iris retraction hooks which has been used to stabilize the bag, but that got I think edited. The point was that after doing everything I actually had to go in for scleral fixation. So sometimes you need to see if it's a very large subluxation, don't waste your time, and you can directly go in for a scleral fixated lens. I'll just show you some one more video where there is a large subluxation. एक मिनट आपको करना पड़ेगा जरा, कहाँ पे है अदर वीडियो, पीपीटी चला दीजिए, उसमें खुल जाएगा. हाँ, okay, so this is a more than 180-degree subluxation. So what do you do here? If you try to fiddle too much, what will happen is there is a chance that this whole lens and everything may fall back. So what I have done is I have already planned to do a SFIL. There is no point when if your subluxations are very large that you keep fiddling. So it is better to do a cleaner surgery, and before opening the wound it is better to dissect these flaps, because once the wound is opened the eye becomes so hypotenuse that it becomes difficult to dissect these flaps. The other important point is that you must do a very good cauterization, because if you leave a bleeder over here, when you are trying to do your subsequent maneuvers, this bleeding would trickle down. It will cause a post-operative vitreous hemorrhage, and the patient is very unhappy if there is the vitreous hemorrhage takes very long to resolve. So you can very well avoid this. Do a very good cauterization when you are after you have dissected your flaps. And now I am going to put a infusion cannula. So this is a 20. Yeah, this is the infusion cannula which is placed 3.5 millimeter from the limbus, and you can connect it to the. This is the infusion being connected. So the advantage is this is going to push the nucleus up and it will prevent it from going down, and at the same time it will stabilize my chamber. So now before opening the wound again, see I have passed my straight needle nasally, that is 1.5 millimeter from the limbus, and this is the 26 gauge needle temporally, and then I open my wound. Having done all these things, my chamber, the hypotony would be created now. So this infusion cannula can be put on at this time, and this you see with the fluid it was very easy to prolapse the nucleus out. Then you of course you need to do a good vitrectomy to clear the vitreous, because This is the vitrectomy being done, and you can actually put off the infusion cannula at this stage because you have an infusion. And here, the side port has been through the air has been injected, and this I have not injected viscoelastic at all. This needle is docked into the 26 gauge needle, and it is brought out. And this suture, this is a 26 gauge needle bent, and this proline suture is brought out. It is divided into two parts. The IOL is tied, and this is Dr. Malik's technique of burying these suture knots, which I'll be showing subsequently, where none of these sutures, there's no suture erosion in any of our patients. So this is the usual SA file technique. After that, this IOL is placed. The two sutures are now pulled, and all the maneuvers have been done under either fluid or air. So we have realized that if you don't inject viscoelastics and they don't mix up with the vitreous, there is less reaction vis-a-vis when you use a lot of viscoelastic, everybody has a tendency of pushing into the vitreous. Now this is a teno suture. A bite has been taken from the bed of the partially dissected scleral flap. It is tied onto itself, and the same suture is then tied to the exiting proline suture. So this secures the IOL in place. Of course, there are multiple ways of doing a SFIL, but this has worked, and I have seen his cases now with 40 years follow-up, and my own cases with nearly, I think, 25 to years follow-up, and they do very well. So this is a bite has been taken from the posterior surface of the partially dissected flap, and this we have published in I think Delhi Journal of Ophthalmology. So this really helps in burying this suture knot very well. And this is the area where there was the sphincter had was damaged, so I'm doing a pupilloplasty. So all these patients, as I said, you have to work out what is going to fit in. Not one technique is going to fit in all cases. And this is the McCallan suture, which I think all of us are using. This is just the same needle, the remaining portion which of the proline suture which was left. I have used it for repairing the iris. And after that also, if you feel at any point of time that your flap is not very well buried, this partial thickness flap, I routinely now also put a suture. The conjunctiva, I just give buried atope vicral suture, so that there is no exposure at all of these patients. Now, sir, time hai ki band kar do?
Both time.
Achha. So this is another interesting case of.
We have time for discussion, anything. But if you want something, what you're talking?
I'm talking about the coloboma part now.
Coloboma, do it.
Okay, so lots of times you may have patients where you have, it's not just the subluxation, there may be other malformations associated. So remember, always look for a lens coloboma in these patients, because what happens is, if you can see this picture, there is a lens coloboma over here. There is no capsule over here. It's not only broken, the capsule does not exist. So that is a difference between these patients and your regular subluxated cataracts. So in these patients, I'll just show you what the problems I fared. Let's see if the video is there, or okay, one video is there. So this is an older video, and here I had planned to put in a Sioni. So I had already created a partial thickness flap, and I was planning to do an SICS. So you see, I am trying to hydrodissect, and however hard I may try to hydrodissect, the fluid wave is not dissecting at all, and the nucleus just failed to rotate. You see, I kept on dissecting. There was no way the wave would reach that area. So these patients where the capsule is actually missing in that area, it's a kidney shaped capsule in that area. There, this technique of trying to put in and trying to rotate the nucleus is not good. So finally I had to actually convert it into an SA file. The second eye which I did, we have published it in this you can read the complete article. The second I was wiser. What I did was, instead of, I realized that the nucleus will not rotate. So what I did, I shifted it to phacoemulsification. I did a in the bag debulking of the nucleus and then took it out, and then I implanted the IOL. So that worked. So the point is that not all patients are going to fit into your standard. There is no like, if you have to do this algorithm that this will work in this, you have to see every patient in totality before you decide what you want to do. Especially in patients with lens coloboma, if you want to do SICS, only go for hydrodelineation first. Maybe you can take out the nucleus, nucleus. Otherwise, if you're just doing hydrodissection, it may be difficult to rotate the nucleus. So you remove the center core, core of the nucleus, go in for aspiration later on, and then put in the IOL. So these are small little things which I have experienced in my practice. And of course, this is the standard teaching that if it is up to 4 clock hours of subluxation, you can go for CTR, but provided your remaining zonules are intact, they're they're not weak. If there is a generalized subluxation, even small 4 clocks of subluxation, I would not go in for a CTR. I would rather go for an SFIL or a CTR with a CTS. So anyway, between 3 to 6 clock hours, of course, you can go for a modified CTR. Nowadays, as I said, I think that going in for CTS with CTR is a choice for all these patients. And if the subluxation is more than 6 clock hours, or let us say more than, let's say, 7 clock hours, I would rather go in for SFIL directly rather than struggling and making a mess. You end up with a cleaner outcome with those in that case. Thank you so much.
Thank you very much. If any particular query somebody has, we will answer that. And scleral fixation, that bilateral scleral fixation is my doing. I taught her and she does better than me now, of course. And that's the best way of scleral fixation of IUL. You will never know after a month whether phaco has been done or what has been done. So scleral fixation, any other method will fail, drop, this will happen or that will happen. But this method of scleral flaps on 180-degree away and then fixing is the best method. Any query about, yeah, and of course she has told about the coloboma of the lenses. They are very difficult to rotate. They don't rotate at all. So don't try SICS rotation in them and taking out. So she told very good tip about that. Coloboma of lenses has to be brought in parts, like do hydrodelineations, make the nucleus smaller, then take it out. So they are difficult to rotate. Anything, any question you have for us, for any of us? The corneopathy part and SICS we are dropping, that you do every day and everybody does that. So I think if there's no query, we say goodbye. Thank you so much. Thank you.